Thanks, Doc. It's a pleasure to speak here. Learn a lot from the doctors and appreciate all our conversations, with the different cases we have. And also want to thank my colleagues in Tampa. I think they're watching virtually, but they may have switched me off in lieu of Sports Center for this talk. No disclosures here. So just to go through the rehab process following a UCL reconstruction, some things to consider are the pre-op aspects, implications of the surgical technique, the general rehab overview, the interval throwing program, and then finally identifying and managing setbacks throughout the process. So some pre-op considerations, and some of this was touched on during the exam, looking at their range of motion and their strength. So the pictures here on the right-hand side were taken seconds apart. So just making sure that the positioning of the patient is appropriate. So you can see on the left-hand side, it can be fooled into thinking that's full extension, but it's getting that through humeral ER. So if we put them in proper positioning, that can drastically change. So just consistency with the measures is going to help, and also just gives us an idea of what the ranges that we're going to be looking for post-op. The symptom reporting, past medical history, timing of the injury, and all these things were discussed earlier, and play into the role of, are we going to attempt a conservative rehab or more of the operative route? Education is a big piece of the rehab process, and an important one to touch on. I try to talk to the players before they go up and see one of our physicians, and just help answer any questions they may have, because I can guarantee they're going to go in the clubhouse and talk to our proposed medical experts and the players, and they can get some varying information. So I think it's a good idea just to attack that on the front end. And then if you're in the outpatient sector, the insurance coverage can be an issue. So just structuring your visits appropriately to where, if they're in a good place, maybe back off on visits, or if they need more, just something to be mindful of. So the education piece, like I touched on, I've heard a lot of different things from players and coaches regarding UCL reconstructions, because we do see it so frequently. So it's just an oil change. Why aren't they throwing harder? Velocity is a big part, right, of coming back. College coach told me to stop doing arm care. So you see a lot of or hear a lot of different things, and it's important to address maybe some of the misconceptions. And to touch on that, there's a public perception, and now this is going on 10 years, and hopefully that it's shifted. But there's some that believe you perform on a healthy elbow to enhance their performance. Is the performance enhanced? And then timing of return to sports. So a lot of information being thrown at coaches, players, parents, and sometimes that information isn't always what we'd prefer them to hear. And then lastly, the player perception. So 42% reported a change in mechanics, and we touched on some of the biomechanics aspect and some of the tech that we have. So an important thing to consider during the throwing program. And then setbacks is something that we're going to touch on later here, with 20% reporting setbacks. So the surgical technique, first and foremost, I think it's just important to speak to the physician and get their sense of intraoperatively what the elbow looked like. How aggressive or how conservative do you need to be with the rehab process? So, of course, you can read the op note, but I think it always helps just to have a quick conversation. What else was done? We've talked about the flexor pronator, the transposition in detail, spurs, loose bodies. All those things are going to play a role into your rehab process. And again, important to have a good grasp on what structures were involved. Graft choice, typically we see the palmaris, but if it is the hamstring tendon, just delays some things to consider, I should say, in regards to some of the training on that end. And then expected post-op symptoms. Oftentimes see some transient ulnar nerve paresthesia, something to keep an eye on and communicate with the physician about if that's something that lingers. And again, I think this was hit on earlier, the posterior tricep tightness, oftentimes from swelling, the capsule may be a little bit tightened. So, in guarding throughout that process. So all things to expect. So the rehab timeline, I think this is a good slide, and I share it often throughout just to educate our players, because it is a long process. It's physically and mentally tasking. So to give them an idea of what the process is going to look like, I think just helps them set up for success, and ultimately splitting up the rehab into 4 different phases. So the immediate phase, intermediate from weeks 4 to 7, the strengthening phase, and then ultimately return to activity beginning at 14 or so weeks. So really immediately post-op, not doing a great deal, some light gripping for swelling, if some gentle range of motion at the wrist and elbow. And here we'll I won't touch on all these different weeks. I think the protocols are pretty well established to help guide you through. So immediately post-op, you see a lot of different presentations, whether it be significant swelling, ecchymosis, so things to, kind of give us a guide of where we're going to target first. So first and foremost of this phase, you just want to protect the graft. So really no aggressive motion or stressing valgus. Protecting the tissue healing, decreasing pain and inflammation. You can see on the right-hand side, we have a player that once he came back from New York, pretty swollen, and then a few days later able to decrease that with a couple different techniques. And then always a good idea, speak with the physician if you don't have a close relationship, get their protocol and understand what some of their range of motion specifics are. So tissue healing and infection control, the infection control piece is one that probably glossed over. A lot really didn't put too much thought into, but we actually just had a player, the first one in my 7 years, that had an infection in his elbow. So things you want to be aware of. What does the incision area look like? Sometimes it can look like they're almost spitting a stitch. But again, communicate with the physician and make sure they can get their eyes on that pretty quickly, just to limit any more significant complications. So once you take off the post-op splint, covering the area, gauze, tegaderm, just so they have a little bit of a waterproof bandage, is helpful. And then early on, the range of motion considerations, in my opinion, I think less is more. But some of the decision-making for the brace settings, again, before you start changing, I would speak with the physician. But, if they're more of a dense person and we know that we're probably going to have to be a little bit more aggressive, we may open up their brace earlier than normal. Or if they come out of the post-op splint and they go right to 0, that's when I may be a little bit more conservative on with their brace settings, just so we're not getting too much motion too soon. So gradually advancing extension in these early on stages and communicating with the athlete to have an idea of where that sensation is as they're getting their range of motion. If it's an appropriate stretch, let's say in the biceps area or whatever it may be. And oftentimes, there is some guarding with this, so some neural inhibition techniques I think are helpful in gaining back that range of motion. Limiting excessive elbow flexion. I mean, early on in those stages, if I'm getting 90, 100, I think that's smoothly. I'm happy with that. I don't really go too much beyond that early on. And then when it comes to, structuring your rehab, I think it's probably more beneficial to spend your time on one direction, let's say focusing on extension versus going back and forth, because I think the carryover of the changes can be lost if you try to go back and forth too soon in this process. So moving on to the intermediate phase, you're starting to initiate some light activity, but in this phase the goal is ultimately get their full motion and then begin some light strengthening. So the bottom picture, you can see player on the bottom left there has some limited elbow flexion with some medial pain. So that's one where we'll make a phone call, and typically a course of NSAIDs will help with that. But again, that's an early discussion that you want to have, that there's a, let's say, not intended result of going through their elbow flexion. But, within about 10 days, that normal motion was restored. So joint mobs is something we'll start to mix in as the rehab stage goes on. We're a little bit more comfortable with, being a little bit more aggressive if there's some limitations with their mobility. So assessing what their appropriate end feels are, and then ultimately helping that guide your treatment. So here's have some techniques on the left-hand side here. So just an ulnar gapping technique, working for full flexion. And then here in the middle, just a distraction force. And again, communicating with the athlete of where they feel this sensation, just to make sure that, there's no ill-intended response to this. And then finally, just some radial head mobs on the right-hand side there. So soft tissue techniques, a lot of the same things that Joe spoke on yesterday. hands, scraping, cupping, dry needling. There's a lot out there, but I think you just want to be mindful of the tissue response. Working through the flexor pronator, the biceps, so all different areas to target during the rehab process. And cupping, I know that was touched on as well too. I think that's kind of my same thought process, as well as, I think it's a good thing to implement for the scar. If you can just see some of the dimpling there in the middle, we want to try to restore appropriate scar tissue. So we won't really spend too much time, but initiating some light forearm strengthening. You can get as creative as possible here. These are some old pictures, so we try to engage a little bit more than just have them sit on the table with these. So really with a lot of the things that we're going to focus on is, of course, their rotator cuff, their parascapular strengthening versus, just something that we would say is, strictly related to the elbow, but appropriate activation throughout the process. And using a towel has been shown to increase the optimal line of force production through the musculature, and then also just adding in some adduction with the ER, increased activity, EMG, and then increasing the subacromial space. So just little things to consider throughout the rehab process. And again, Eric touched on this yesterday, the down and back and some of the upward rotation. I think those are things to consider as well too. Assessing that patient, whether it's at your baseline or post-op, and ultimately, helping some of those things guide your treatment and exercise prescription. Neuromuscular stabilization. Kevin did a great job on this yesterday, so I'm not going to touch on it too in depth here, but progressing it, make it challenging, engaging the core. I think all those are things to, target with this athletic population just to meet the demands. Skip through some of these here. So now we're at the kind of the boring stage, I think, for rehab for these guys, is that advanced strengthening phase. They have their full motion. They're starting to progress their activity, but, this is definitely an important phase before we get ready to begin a throwing program. So some of the goals here: increase their strength, power, endurance, maintain full elbow motion, and then gradually initiate sport activities. And during this stage 2, you're starting to see their weight room activity increase. So important to communicate with strength staff and develop an appropriate program and work closer towards some symmetrical strength. Weight-bearing exercises, have some box step overs, walks. I think some of the planks that Kevin was doing yesterday, were great as well too. And then we're starting to incorporate, like I said, some strengthening in the weight room as well. So self-stretching techniques. We have here a weighted elbow extension. If we're having some issues gaining back extension, this is a technique that, we may implement, but it's just some take-home points. The stretch should be felt over the anterior aspect, over the biceps. We're not looking for any response posteriorly. Typically we do a lightweight and a long hold. Another thing to possibly consider, I can't say we use it frequently, would be a dynasplint, and that's something that we've incorporated on a few occasions just to help gain that motion. And then weighted elbow flexion. I haven't used this in a long time, but just another technique if there may be some guarding, things like that to help restore full motion. Touched on this yesterday, but the sleeper stretch, we'll just go through that one here. And now on to the return to sport phase. So we're starting the plyos. We're beginning an interval throwing program, and I think that's changed, and I'll probably touch on that here shortly. I think from the 4 to 6 month range, you're seeing a various timing that the physician preference, but ultimately, and again, we'll get to this later. We got to make sure that the athletes are appropriately prepared to begin. So, looking at adding in double arm plyos, single arm plyos, again, you want to make sure good shoulder motion, strength, elbow, all things to assess before we just start to progress. Perturbations like Kevin had mixed in as well too. So, there's a lot to advance and challenge the athletes as they get ready to start throwing. So once we're starting to think about an interval throwing program, getting their goniometric assessments, their strength testing, and also, making sure some of the weight room exercises are where we want. So I would say we don't want to just start them based off a timeline. If it's 4 months, 5 months, whatever it may be, you want to make sure they're in a good place. So I think we're seeing more and more a shift maybe away from 4 months and just making sure that they're as strong as possible, the motion's good, things like that. But really the throwing program I'll touch on here, I think in the 1 or 2 slides, it's a gradual progression where the flat ground portion that on average is about 4.5 months, moving on to a mountain progression, which is about another 4 months, and then incorporating download periods as needed throughout. So I think there's been a lot of really nice talks about some of the objective data and how do we monitor the throwing program. So those are all important things to consider. So, I wouldn't get too in depth with the specifics of this slide, because I think as we've evolved, our specifics of the throwing program has changed. But really, it's just a gradual increase in the volume and distance and intensity throughout. So, starting at, let's say if it's 45, 60 feet, and then building up their volume, their number of days throwing. But like I said, I think if we probably polled everybody in this room, there'd be a lot of different throwing programs, and they can all get us to ultimately where we need to be. But as long as it's a progressive approach, I think that's the right move there. Important aspect of throwing programs is the download period. And based on the timing of the year, you have to consider if that's an active recovery phase where, they may continue some light catch, or a complete shutdown. So a number of different factors to consider there. But I think the download phase is important. Objective data, I think that's something that is an evolving area, and something that we're going to learn more about, to have a true informative process that guides our rehab versus just going right off the calendar. So, I think there's some factors to consider in how we present that information and how we help it guide our throwing programs. But I think that's going to be the next step to, try to get these programs as appropriate as possible. We'll skip over here to the other side, but the mountain progression, again, just a gradual increase in their volume, their intensity, and then once they're back to live BPs, batting practice, things like that. I will say some of the most common times of a setback is at that next jump, whether it's from the flat ground to the mound to BPs to game. So those are areas to really just be on top of their volume, their recovery, to prevent some of those setbacks. So weighted balls, Mike's going to touch on this, I think, in a later talk. But some things to consider would be what's their previous exposure. What's the purpose of implementing the weighted balls? If it's mechanical, velocity. I think you have to be careful, but it's probably worth the discussion. What's the timing of the implementation? Sorry for having to keep watch this. It's probably a little. I think we have a knee talk later, but making sure that the drill is appropriate for the timing of their rehab, and that we're comfortable with the stress that it's going to add. But ultimately, it's also another aspect is to consider the volume that it brings with. So you don't want to just keep loading all this activity on these guys, because we do see a lot of overuse, especially in the shoulder when it comes to the rehab process. So setbacks, I put in parentheses, I think there's common things that we see a lot during the throwing programs or the rehab process, but there's expected and normal soreness throughout, and I think it's just managing some of those discussions with the players of what's normal, what's not. I think the best throwing program is one that you modify. They may come in and just feel like they're not recovered, and that's no issue. Give them a day versus preventing something more significant. So the subjective reporting aspect is important. Continuing to monitor their mobility, motion, strength is definitely important throughout the process. The rehab protocols, I think they're guidelines to help manage the rehab process, but I wouldn't just stay strictly to the timelines versus seeing what's right in front of you. So the assessing the volume and intensity of activity, the overworkers or underworkers. Oftentimes if we have a player that's maybe rehabbing at home and they come into Tampa, the workload imbalance, may be there. So you want to just gradually build them back up. And it is okay to download arm care exercises. I think, we see a lot of overuse, tendonitis in the shoulder, and then oftentimes it's just due to overworking. And then lastly, communicating with staff and the physician. A lot of the physicians in this room are very accessible, and I think they appreciate, the updates. So whether it's check-ins for their motion early on, or check-ins, on FaceTime, Zoom, whatever it may be, I think it's important to have the physician involved throughout the process. So in summary, it's a long rehab process, and I think probably more so mentally than physically. So there's, getting your mental conditioning staff involved and others, I think is important as well too. Don't advance just based on the timeline. Make sure they're meeting all your benchmarks before moving forward. Educating, I think it's a big aspect of it, whether it be coaches, parents, players, all that are probably in need of some good information. Frequent reassessments, throughout the rehab process is important. And then, the last thing is just communication, whether it's amongst your staff, the player, whoever it may be. But I think that's some key take-home points there. Thank you.